How do I correctly pronounce your last name? Cicada?
Gotcha, just like you guessed.
Okay, gotcha.
Take one pass it around.
Like
Yes.
Thanks.
Yeah.
Thanks. These are right. Yeah.
I'm not sure I want to be in this room. Are we broadcasting?
Yes,
Okay.
so it's
I do.
9:33, and I will call this meeting to order. Introductions, my name is Gary Merchant, I'm the state rep, and also chair of the Affordability Board. And to my left,
I'm Representative Jess Edwards.
Senator Cindy Rosenwald.
Bob Woodward.
Jason Hazes. Kurt Williamson.
and on the Zoom, I think we have the Fahey.
Todd Fahey, good morning.
And Todd is the clerk of the board. So in saying that, need to establish a quorum. We have 1, 2, 3 board members here, so therefore we have a quorum. I don't need to elevate somebody who's an alternate to a full member. In regards to the agenda, is anything on the agenda that people want to move around, change the sequence of, or?
There's something I would like to add. I've asked informally about it, and it can either be an agenda item today or in the future, but in the initial law that we passed, and I think it's still in 126 BB, there was a provision for establishing a fund where outside entities could contribute money to help pay for the functioning of the board. And I would like to have that established because I would be happy to make the initial donation to the cause. I know that AARP was a strong advocate for investing taxpayer money into this effort. And I'd like to give them an opportunity to contribute since they think this is such a great idea.
Absolutely. One of the things in the past that we were told we had to do before we could accept any money is creating the rules for it.
So that's, I don't know where we are. I just want it established. I don't much care about the process.
Fine, and I think what we should do at that point in time is find somebody, if you don't mind, Williamson, to within the department to help us in rule writing.
Yep.
We move forward with that, which I think I totally agree with you.
Would that be Rob Barry?
Rob Barry. Well, it may not, Rob will be the person to spearhead it, but there's somebody else, it's Melissa, who does the actual rule writing. So. Absolutely. And thank you for being willing to strike the donation, Representative William Edwards. Anything else we want to talk about before the agenda? Mr. Fahey, is there anything you want to add to the agenda?
No, thank you.
Okay. So we have approval for the minutes of January 29th. Is there anything on here that people, I know?
I would move that the minutes with Representative Edwards' changes.
I have, if we're on the draft, I did email a recommendation. I didn't complete the recommendation, may I, Mr. Chair? On the section where it says October and December minutes of the draft minutes, it's not numbered, but it's lines 9, 10, and 11. I would request striking the sentence that begins Todd Fahey and ends with his prior position. I don't think that that sentence adds anything to the discussion that precedes that sentence. It was clear that I accepted that my opinion and my position had changed, which is why we changed the wording from supports to supported. So that particular sentence seems inflammatory to me. And I would request that the board strike it.
No, just to be clear on this, the reason why I think we had that inserted was the fact that there was a discussion about changing from supports to supported. So if we just strike that, we could be striking that conversation.
Well, how about just striking from where on line 10, it picks up after supported and says, and noting Representative Edwards' position. I think I is the one that noted my position was different. I didn't need Mr. Leahy to do that for me.
Mr. Chairman?
Yes, Ms. Leahy.
Yeah, can I speak to that? Representative Edwards,
Please.
respectfully, you continue to talk about us being inflammatory and people to be, being inflammatory. And, honestly, you continue to ascribe malevolence to people on this board, and I'm just growing a little weary of it. We're all volunteering our time to do the best we can. I have not acted in one way to do anything to undermine any member of this board, you or any other. So if we can just stop with that and get to the business of the board, I'd be grateful. So forgive me for being so blunt, but I've heard
I
it
think the
every
discussion is
meeting thus far.
around striking.
Can I finish, please, Mr. Chairman? I've heard it every meeting since I've been here. And
Right.
it's just, we're all trying to do the best we can to launch this board and to do its good work. And I mean, I think when you say that, there's nothing inflammatory. I mean, that was somebody taking the notes.
So
in the
are
minutes.
you in favor of striking the and nothing portion of that sentence? Because I am putting forth that position as a recommendation to the board to strike that half of that sentence. I think that sentence is objectively inflammatory.
I take no position, Representative Edwards, but I'm just going to say I've been on the board now for a long time trying to get it off the ground. And I just think we need to get to the business of the board and stop suggesting that people are having an agenda here, because I don't think that's true. So it's every meeting, it's every moment, and we have a lot of work to do. So I'm sorry to be so blunt, but it's just, I'm giving of my time to this board and I just want to do its work.
So I hear the recommendation, Representative Edwards, thank you. I think what I suggest we do, the minutes should reflect what happened. So therefore, I would ask Mr. Williamson to go back and look at the tape and find out what happened. Because if that was what happened, then that has to reflect what happened.
That happened, but that isn't completely what happened. There are things that are left out.
Then
That's
you-
why the simplest thing to do, the least fuss, is just to strike at on line 10 of that, all the words of that sentence that goes, and noting Representative Edwards' position today is at odds. Because I noted that at the outset of that conversation, that my position to that day was different than what I had agreed to in the meeting.
So if we end up parsing the words and striking noting.
And
put down
noting, yeah,
supported, and Representative Edwards noted his position today changed.
that would be fine too.
Okay.
I just don't need to be,
So therefore, we're still retaining, if you will, that you, during that conversation, made a notation to the board that you had changed your position.
right,
Okay,
I changed my position.
all right.
From that conversation, I tried to empathize with the idea that all the legislators should try to be unanimously behind a single legislative position. I tried to accommodate that. Later, after the meeting, I decided that probably wasn't an appropriate policy for me.
So, Mr. Williamson, have you got where it says, and
Yep.
Representative Edwards notes his position stays at odds?
Yep.
Okay, make a change.
Thank you.
With those edits, can we improve the minutes then?
I'm going to abstain because I wasn't at the last meeting.
He wants to basically say is, and sort of noting is that.
But I did
Edwards
make
noted
the
his position
motion.
stays at odds with prior decision. That's all. Okay, so it does reflect what happened, and I'm okay with that. Um,
Am I, replacing this?
it's said yes,
Did you want me to be,
we don't need to, because we have a quorum.
I know, but
Oh.
if he's absent. then
Senator
I'll become-
Abbas, yes, you do.
Thanks.
Thank you. So I'm going to, at this point in time, Senator Abbas is not here today. And the alternate to Senator Abbas is Senator, Dr. Sherman. And I'll elevate Dr. Sherman as a full member in replacement of Senator Abbas. For the record. So, in saying that, we have a motion on the floor, please, to accept the minutes for January with the edit. So moved. There we go. Okay, have a second, please.
Second.
Thank you. All those in favor say aye. Oh, I can't take roll call, got roll call. We have Zoom. Senator Roosevelt, same,
Abstain.
Dr. Woodward. I agree. This.
Yeah.
Dr. Chairman. Representative Edwards,
I'm in favor.
okay. And Mr. Payne,
Aye.
and the chair says yay as well, so we have approval of the minutes. Now, one of the things also on the business of the board was Mr. Williamson. I think you've done some great work on the advisory council. Do you want to?
Yeah, we have 10 out of the 12 individuals now on the advisory council. We're just waiting on 2 individuals to nominate their designee. So hopefully we'll be able to welcome them fully within the next couple months. And I'll send around the full list of individuals. But we have 10 out of the 12 now, so we're almost there.
Is there anything else you want to bring the board up to speed with the executive director?
I don't think none at this time. We have a packed agenda, but we should get through.
Thank you. And then also as far as I did get a comment back from Attorney Barry, we cannot have a Zoom meeting. I was trying to have a quote meeting with Dr. Ezes, Dr. Woodward and myself. And also with Mr. Williamson and a couple of people about the data. And trying to come up with what we need for data and so forth. Unfortunately, because both of them are alternates, even though they're alternates, they are considered board members, and therefore that would create a quorum. So in order for us to do this, we have to have another public meeting. Again, it's not something where the other board members have to be present, but it does have to be held in public. So therefore, if the board members want to be there, I'll probably schedule a meeting sometime in April to try to accommodate that. But I just want to be clear that board attendance is not critical. Although you're invited as a board member to be there as well. They'll be open to the public. Okay. Regards to the speaker. Yeah.
And Antonio Chacha.
Cha-cha. Boy, I'm gonna have a tough time with this one. Mr. Cha-cha, do you want to, at this point in time, take it away? But before we get into it, do you want to introduce?
Yeah, Antonio, you have a great slide introducing yourself, but just very quickly, Antonio is the president of 3 Axis Advisors in 46 Brooklyn. They're an independent research organization, nationally recognized as experts in the supply chain and drug channels. Really excited for Antonio to be here to walk you through his research and to inform the ensuing discussion. So Antonio, I'll go ahead and turn it over to you. And then also, if you have questions as he's going through, as always, raise your hand. I'm going to try to wait to the end of the slide, just so we don't interrupt his thoughts, but as you're always welcome to ask a question.
Great. Thank you so much. It is great to be with you all today. I'm going to pull up my slides here. I trust you all can see them at this point.
Yep.
Look, just by way of framing, it was funny. There was an article in Axios last week that was asking about the progress of prescription drug affordability boards across the country, and really basically saying, look, these things have been around for a couple of years, and so far there's not really a track record of lowering costs. And I think that's probably somewhat of a oversimplified and unfair view of PDABs to say, hey, where are they today in terms of achieving their goal of lowering costs? partly because I think it needs to be an iterative process, but secondly, because if I could be critical of the PDABs thus far, in one way, it would be that I don't know if the boards have done a good job of answering some fundamental questions before they engage in their pursuits. And that question is affordability for who? In the drug supply chain, as we're going to talk about today, we have bloated, inflated prices. Surprise, surprise. But those prices are being set with the intent of them being the best case scenario for the entity that is setting them, whether that's the manufacturer, the wholesaler, the pharmacy, et cetera. And as a result of those bloated prices, which aren't set based upon traditional market forces, what our system is designed to do is create a negotiated end experience for the end purchaser. And so we rely on intermediaries to create that negotiated experience. I think the goal of PDABs is maybe to have government help facilitate how that occurs, or maybe government actually creates the negotiated experience. But it's important to understand that there are purposeful policy trade-offs and arbitrage practices of drug channel intermediaries that often takes away the savings that the marketplace may in fact be yielding. So the thing I'll just stress at the onset is I think it's incumbent upon the board to settle on a philosophy, if you will, of who is affordability intended for? Is it the patient, the plan sponsor, the government program, some combination of those? But if your focus is going to be on how the patient or the plan sponsor is being charged, well, what that means is that the pharmacy benefit manager or the PBM are going to be an integral part of this. So by way of introducing myself, I came from the pharmacy world. I did a few years at the Ohio Pharmacists Association. I did not know a lot about drug pricing when I started in 2010. Pharmacies, like many stakeholders in the drug supply chain, want better treatment, if you will. And whether they deserve it or not, pharmacies in Ohio were complaining about massive underpayments within our Medicaid managed care program around 2016 and 2017. Pharmacists were arguing that the payments that PBMs were instituting within our state Medicaid managed care program were not balancing the books or providing enough margin for even profit. And so as a result, we were seeing a lot of pharmacy closures throughout the state of Ohio. We saw about 200 net pharmacy closures. That includes openings. So 200 pharmacies deleted off the map in Ohio in just under a 3-year period. Now, all of that was not attributed to Medicaid, but a huge portion of it was. The challenge, though, that I found was that while pharmacies were getting underpaid on medicines, the state was not saving money. And so those two things didn't add up. So my background being in pharmacy, but also journalism, I found it strange that there was so much focus on the prices of prescription drugs, yet when the payouts to pharmacies were declining, the end payer wasn't saving money. Nobody was really paying attention to whether or not value was being lost in the middle. To make a very long story short, we helped the state of Ohio uncover $245 million of hidden spread pricing, where PBMs were paying pharmacies one rate, billing the state a different rate, and pocketing the difference without disclosing it back to the state. We took all that data and said, hey, you know what, this is really fascinating. It's publicly available. Let's publish it. So I launched a nonprofit organization called 46 Brooklyn Research in 2018 to do this, to publish drug pricing data for free. It was meant to be a hobby to annoy my wife between the hours of 9 p.m. and 12 a.m. I did not expect that it would grow into anything. It did. It necessitated creating a consulting firm that was intended to just basically do lawyer work. But today, my consulting firm, 3-Axis Advisors, we do work for state attorney generals, state auditors, government programs, Medicaid programs, provider groups, plan sponsors, research firms, industry disruptors, et cetera. We run the gamut, but the mission is essentially the same in everything we do, which is demystifying prescription drug pricing for the purposes of creating a better aligned value for what we're buying for medicines. So just by way of framing, let's talk about this ecosystem. Drug companies sell drugs to wholesalers, who sell drugs to pharmacies. Pharmacies are predominantly reimbursed by pharmacy benefit managers or PBMs on behalf of health insurance companies. There are other intermediaries in the drug channel, like group purchasing organizations, pharmacy services administrative organizations, repackagers, relabelers, rebate aggregators, benefits brokers, and consultants. We'll probably not talk about these other players a lot, but we're going to focus on the 5 main pillars today. Now, in a conventional sense, we think of these layers as being distinguishable from one another, meaning Pfizer is a drug company, McKesson is a wholesaler, Walgreens is a pharmacy, a PBM is Express Scripts. But in the new era of the drug supply chain, lines are blurred. So the same companies who might be wholesale or have wholesaling businesses could also be pharmacy companies. PBMs are health insurance companies. So here's just a look at the Fortune 50 list as of last month. What you can see is that United Health Group, Costco, CVS Health, these companies represent different layers within the drug channel now. You know, United Health Group, CVS Health, and Cigna being most relevant, they have 4 different layers of the drug supply chain under their enterprise. And if you look to CVS Health, they just launched a new company called Cordavis under their umbrella that essentially is taking inventory of products and setting the prices of them, thus now blurring the line into the drug manufacturing sector. So while we typically think of all these working against one another, understand that the traditional friction that we've relied upon in the drug channel has been distorted because vertical integration puts the same points of friction under the same umbrella. So while there are smaller independent players at every layer of the drug channel, for the purposes of today, let's just assume that the primary goal of the largest publicly traded companies and even the smaller ones, all right, is to make more money. Now, for publicly traded companies, it is their fiduciary obligation to make more money and bring it back to shareholders. This is not an inherent evil, right? But it is important to understand that money will be guiding the decision-making processes of these companies. Independents might want to make more money, but publicly traded companies are required to do so. So in order to control prescription drug costs, we must rely on traditional forces of friction and a proper calibration of incentives in order to ensure efficient spending while also maintaining robust access to medicines that we need. So when people ask me as a drug pricing nerd, what's the price of a drug? I always laugh because there is no such thing as the price for a drug. There are different ways within the alphabet soup of drug pricing benchmarks that we could quantify or assign a value to the price of a medicine, but understand that a medicine is being sold through this complicated layer of a drug supply chain, with every single transaction having a gross price and a net price. So you're going to encounter a lot of acronyms in this space, which is a way that I'll just say for the sake of this discussion is that if your job is working on affordability, I go back to my original question, affordability for who? Which one of these benchmarks are you aiming to ultimately achieve success on in providing affordability on? Anything that you do from a policy perspective, unless it has a cascading effect all the way down the drug channel, you might be providing affordability in one direction, but there's no guarantee that that savings goes through to the end of that transaction. So with that acknowledgement out of the way, let's talk about what's happening with the list prices of drugs. This is all publicly available data from our website at 46 Brooklyn Research. We track drug company prices on a week-by-week basis. So you can compare on a drug maker by drug maker basis, year-by-year basis, to see what's happening in the marketplace. Which drugs are going up, which drugs are going down, which drug makers are engaging in price increases, which ones aren't, and how do they contextualize against prior years of experience? Well, from 2015 to 2020, the number of annual list price increases as governed by wholesale acquisition cost or WAC the number of price increases over those years has been on a downward trajectory, meaning each year had less brand drug increases than the year before. Now, that all changed in 2021 with just over 1,200 list price increases. 2021 had the highest number of brand list price hikes since 2018. 2022 even lapped 2021. And when in 2023, we saw the highest number of price increases in over a decade. January 2024, we saw 907 list price increases and 28 decreases. So that's just counting how many times a brand drug takes an increase in price. That's not really telling us a whole lot. It's just saying it's treating every increase as an equal event. But we know that that's not the case. Different drugs have different popularity or usage. And so it's very important to contextualize. Let's say if one drug takes a price increase of 10%, but 500 people take it, it's noteworthy. But what happens if a drug that 5 million people take has a 1% increase, far more impactful to the overall system? So we aim to contextualize this as much as possible. In 2019, the median price increase, and since 2019, the median price increase of brand drugs has hovered at or below 5%, which is much better than it was before that. However, again, that's just median. One of the benefits of Medicaid data and the data set that we used to uncover the spread pricing scam in the state of Ohio was that Medicaid, CMS tracks all Medicaid expenditures in every state across the country on a drug by drug, quarter by quarter basis. That gives us an ability to create proportionality with which we're consuming drugs within the patient marketplace. So we take all that utilization data and we overlay it with all these price changes and ask the question, what is the weighted average impact of all these drug company price increases and decreases? And as you can see, the weighted average price increase has been on a downward trajectory since 2013. And in 2024, really cratered because of a few decreases in insulins and inhalers that happened here in January 1 as a result of the lifting of the AMP cap, which is a policy that basically capped the amount of rebates that drug companies had to pass through to Medicaid programs. So this looks like a kind of rosy picture here. If you're saying, hey, drug prices, we're not getting as much over time. Maybe we're getting a little bit more over time, but the weighted impact is going down. Understand that with all of this, everything I just showed you was list prices, okay? And underneath those list prices are, as I said at the onset, big negotiated discounts that drug companies pass through to drug channel intermediaries and government programs. Drug companies are required by law to pass through massive discounts to state Medicaid programs and 340B covered entities and other government programs as well. They also pass through big rebates and discounts to PBMs because of exemptions to federal anti-kickback laws. Drug companies can pay a lot of money to PBMs in exchange for preferential treatment when the PBM decides which drugs to cover on their formularies. Now, federal officials have been questioning the utility of rebates due to the likelihood that because manufacturers can set whatever prices they want, manufacturers are likely treating these rebates like taxes and essentially pricing them into the overall list prices of those medicines. Now, it's important to understand that while drug prices are going up every year, the rebates are actually growing at faster rates, meaning that while list prices are going up around 5% every year, the growth rate of rebates is going up at a more significant pace. So the discounts, the rate of growth of discounts are outpacing the rate of growth of list prices. But that's just looking at changes over time. Because of policy, scrutiny, or a number of things that are changing in the marketplace, while drug companies have been de-emphasizing their reliance on list price growth over time, it is giving way to increased launch prices of medicines year over year. So if public policy is designed to say, hey, we want you to keep your drug price increases below a certain speed limit, drug companies can respond and say, okay, if you're unhappy with when we increase prices year over year, and you'll penalize us if we increase prices too fast year over year, we can just front load the price more to be less reliant on price increases over time. Now, I'm not saying that that's what's happening, but the data suggests that that there's a de-emphasis on list price increases over time with an increased emphasis on increased launch prices over time. So I'm sure you're probably sitting there saying, okay, like, what does all of this mean? So are brand drug costs going up? Are they going down? Are we getting a good deal? Well, as I said, because brand drug company rebates to PBMs, insurers, and rebate aggregators are confidential and vary widely from plan to plan and program to program, it's very hard to figure out the real price of the drug. But before we blame PBMs and health insurance companies for all this mess, understand that government programs like the VA, Medicaid, 340B programs, because they're required to get some of the largest rebates in the marketplace, they're essentially getting best prices while everybody else gets worse prices. And unfortunately for small payers and patients who pay out of pocket, they end up picking up a disproportionate share of the overall list price of a drug. And because different PBMs and different health plans promote utilization of different drug mixes, it makes it very difficult to make apples to apples comparisons among plan sponsors, essentially, a worthwhile endeavor. Regardless of whether any of this is okay, and my bias is that I don't think the system design is okay, this inability to determine what a fair price should be hinders the ability for true market forces to pressure all drug supply chain participant margins and promote quality and efficient spend on medicines. Here's how the system is supposed to work. In America, we want new drugs and innovation. We want to get better. We want to be healthier. We want to live forever, right? Drug patents we give to brand drug manufacturers. It gives them the ability to set prices, and thus that patent and that ability to set prices gives manufacturers the incentive to bring new drugs to market. In America, we grant those patent exclusivity deals with a catch, that eventually that exclusivity will lapse, and generic and biosimilar manufacturers will bring competing versions of a drug to the market. By opening the door to new manufacturers to make the old legacy product, competition is designed to drive prices down. In order for brand manufacturers to create new revenue opportunities, once they lose those patents, they need to bring new drugs to market to replenish the revenue pipeline. Increasing brand drug costs ideally should be offset to a significant degree, not entirely, by deflating generic and biosimilar drug savings. That's how the system is supposed to work. Let me give you the bad news. Here's how it actually works. Many new drugs are new and innovative, but many others are just slightly modified versions of the same old drugs. And instead of competition actually working after patents go away, drug manufacturers can use rebates, thanks to anti-kickback exemptions, to entice PBMs to cover more expensive drugs that may have negligible benefits. Those rebates drive drug companies to raise list prices higher and higher. Excuse me one second. Sorry. Those rebates drive drug companies to raise list prices higher than they otherwise would than if the rebate didn't exist. Patent thickets that drug makers can utilize can delay the generic and biosimilar competition that we rely on. And after patent exclusivity, the door does open to new manufacturers, and competition does usually drive down the cost of products through generic and biosimilars. However, most end payers are charged rates based upon unrelated inflated sticker prices. Thus, the benefits of generic and biosimilar deflation often do not end up getting passed on in full to the end payers, which ends up inflating overall drug spending. The metaphor that I usually use is, think of new brand drugs as we have a bucket, and we're constantly pouring water into the bucket, representing more spend on brand drugs. We rely on a hole at the bottom of the bucket, which is generic and biosimilar competition, to relieve the pressure from the increasing water that we're pouring into that bucket. If for whatever reason, the drug channel can engage in ways to withhold the savings that that marketplace is providing, it essentially is tightening the size of that hole, causing the bucket to overflow in aggregate. So regardless of where the dollars go, I'll go back to the question I asked at the beginning, which is, what do we want drug pricing policy to actually accomplish? Rebates are negotiated or government mandated discounts that are enabled by special exemptions to federal anti-kickback laws. Those discounts are used to fund a variety of government priorities: Medicaid for the underserved, Medicare for our senior population, the VA for our military. We use rebates to lower insurance premiums. We use rebates to pad insurer and PBM profits. We use rebates for provider healthcare services and profits through the 340B program. So drugs have high list prices and big negotiated rebates. But those rebates don't work like they do in traditional marketplaces, where they go to offset what was being spent. We take rebates and often use them for other priorities. So while we're focused about, oh man, these drug costs are so high, at the same time, we've been taking a lot of the savings from drugs and using them to buy other priorities. So as a result, our system has higher prices where the value of discounts don't always make their way to the end payer. As such, it is very important to focus on list prices of medicines, but we also have to focus on the size of the discounts and where the discounts are going, which is arguably equally as important. And that's because essentially these prices are fake until they're real. The list prices of drugs are wildly overinflated relative to their actual end cost. PBMs use those list prices, average wholesale price, as the basis for their pricing guarantees to pharmacies and plan sponsors. Brand name drugs have high AWPs that are offset by negotiated rebates and discounts that make those net prices lower. We just talked about that. But generic drugs also have high sticker prices that are derived from brand name drugs that in no way reflect the actual prices pharmacies pay to acquire those drugs. In both regards, the actual prices of both brand and generic drugs are completely hidden from the plan sponsor and the patient. Oftentimes, you will hear drug supply chain participants say, we provide so much savings in this marketplace. And usually what they're doing is they're quantifying their savings based upon the bloated prices that many of them are responsible for creating in the first place. Think of them as the Bed Bath & Beyond coupons of medicine, if you will. So let's talk about the fallout of these fake prices. Here we have a boring old bottle of generic Nexium. The AWP, the average wholesale price, which is derived from the wholesale acquisition cost. Think of both of those acronyms as being proxies for the list prices of the drugs that are set or derived from the list price set by the manufacturer. Those prices are not set based upon traditional market forces. While the list price, the AWP of this generic Nexium in June of 2020 was just around $800. Yet when you look to what pharmacies actually pay to acquire the drug using National Average Drug Acquisition Cost, which is a survey conducted by CMS nationally, or Alabama Actual Acquisition Cost, which is a state that mandates that pharmacies disclose the cost that they pay to actually acquire those drugs. What you can see is that the AWP is 47 times higher than its actual underlying cost. So there's a big gap between the sticker prices and the real prices. We typically refer to that as SICPO, or supply chain profit opportunity. This gap between the sticker price and the real cost provides everybody an opportunity to engage in sleight of hand to make money off the delta. And so what does that ultimately enable? Things like spread pricing. I mentioned before, our start in this marketplace was helping the state of Ohio uncover $244 million in change in spread pricing in just 1 year of our Medicaid managed care program, where PBMs were paying pharmacies one rate, billing the state a higher rate and pocketing the difference. It equated to 31.4% of gross spending on generic drugs. it is a ton of money from a context perspective. Just one way that a PBM can distort the underlying cost of the medicines, but again, a supply chain participant withholding the savings that the marketplace is designed to create. In Ohio, this created a huge controversy that spread nationwide. Ohio Attorney General Dave Yost, who was previously the state auditor who validated the crumb trail that we created with reporters from the Columbus Dispatch, sued one of the largest Medicaid managed care plans, Centene, for $88 million in a settlement achieved in 2021, got $55 million in Mississippi, and set aside $1.1 billion for states across the country. If you're wondering, like, why is this stuff new? Well, this was the first settlement that any state attorney general had ever achieved against a PBM for engaging in drug pricing sleight of hand. And it was one of the largest healthcare fraud settlements in the state of Ohio history. To give you a framing and a visualization of how significant this is, my firm did an analysis in the state of Michigan where we had 450 pharmacies in the state hand over all their reimbursement data. So we got to see what were 450 independent, small, and mid-sized chain pharmacies being paid for drugs in the Michigan Medicaid managed care program. We then tracked that against the underlying cost of the drugs, and then tracked that against the overall cost that the state was incurring as a Medicaid program. If you could burn a chart into your brain to say, what is spread pricing? This is it. The blue line represents the underlying cost of medicines. The green line represents what pharmacies in Michigan were being paid for those drugs in the Michigan Medicaid program. The orange line is what the state of Michigan was being charged for those same drugs weighted the exact same way over a 2-year period. As you can see, the cost of medicines are going down. The payments and the margins to pharmacy are going down. The cost to the state was actually going up during that time period. That's looking at generic drugs. Let's go back to the brands. What we have here is a hypothetical brand name drug. The drug maker charges a $100 list price, but because of all the differentiated negotiated experiences of rebates, they might only bring in $50 off that drug. But as you can see, results may vary based upon the size of those discounts. As I said, Medicaid programs are required to get the best price in the marketplace, meaning they're getting the biggest discount off that $100 list price. Then you have the big four, which are federal government programs. They're getting a worse discount than that. A Part D plan sponsor, worse than that. A large employer, worse than that. And then a small employer or a patient that's in essentially working their way through their deductible, they're getting stuck with an overall share of the burden of a high list price product, even though the manufacturer might be getting only $50 when all the books are collected. So regardless whether any of this price discrimination is okay, and again, my bias is I don't think that this is a good way to run a marketplace, understand that these rebates are the key enabler that allows the drug supply chain to capture the benefits of this opacity. One of the reasons that rebates are being so highly scrutinized is because today they're worth over $300 billion annually, according to Drug Channels Institute. Well, obviously that amount of money is significant and people would love to get their hands on them. Well, the way that it's supposed to work again is that drug companies pass big kickbacks and rebates back to PBMs in exchange for coverage. But the rub has been whether or not the value of those rebates are making their way to the end payer, meaning the plan sponsor or the patient. Well, the criticism of PBMs in the past was that they were taking too great of a share of what was being characterized as rebates. Once the federal government started scrutinizing where the rebates were going, PBMs started to shift how they were collecting and retaining those dollars. So in the past, every dollar that a drug company passed to a PBM was considered a rebate. All of a sudden, over time, as more plan sponsors started demanding for the full value of those rebates, PBMs started recategorizing rebates as other things so that they didn't have to pass them through. So a plan sponsor might say to a PBM, I want 100% of the rebates. The PBM was relying on those rebates as profit or as ways to pass along to health plans to lower premiums. So they would say, look, we'll finally give you the 100%, but we get to define what's a rebate. And so now all of a sudden you've seen PBM starting to gerrymander the definition of what a rebate is and isn't. So even though there might be monies that are being passed from a drug company to a PBM, they're being considered something very different now. So over to the right here, I have different phrases that PBMs are using to recategorize what drug company compensation is, such that they don't have to pass it through to the patient and the plan sponsor. But some plan sponsors are even getting wise to this phenomenon. So what PBMs have started doing is creating new companies called rebate aggregators, or as I like to call them, rebate alligators. Traditionally, the drug company negotiated directly with the PBM, and all that drug maker compensation was considered a rebate. As I just told you, PBMs are now changing the categorization of some of those dollars to be essentially administrative fees. Well, because of the increased scrutiny, now PBMs have said, okay, we're going to create a new company that lives now between us. CVS has a company called Zinc, Express Scripts has one called Ascent, and Optum has one called Emissar. These new companies live now in between the drug company and the PBM, acting as essentially like a group purchasing organization, where they now negotiate on behalf of their parent company and other competitors to then pass through those rebates once they negotiate them. But of course, they get a cut, and that cut has been growing significantly over time. So if I'm a plan sponsor and I've worked with a PBM to achieve 100% rebate pass-through and 100% pass-through of all the administrative fees and gobbledygook that you see to the right, well, the PBM can, quote, comply with the on-paper version of the contract in passing through everything they've received, but not necessarily not be required to pass through all the money that has been collected by their new affiliate company that now lives in between the PBM and the drug company. Regardless of whether any of this is okay, and I'll tell you that there's litigation right now that says that it's not okay, the fact remains that the higher the list prices rise, the more price concessions a PBM can collect and retain. To give you a sizing of how significant these rebates are, here's an article from Axios a few years ago that examined the list price of Lantus, which at the time was $283 per vial. The net price of that product was $37 per vial. So that gap is the difference between getting the rate that is close to what the drug maker brings in and overpaying for that product. So what types of distortions do these create and bad incentives? Well, drug companies want to retain their market share after they lose patent exclusivity, as I explained. Well, one of the ways that they could do that is by providing big kickbacks back to PBMs to essentially to keep the money going. So in some regards, we use rebates to try and lower the net cost of products, and sometimes that happens. But then you have a drug like Tecfidera, which is a very popular multiple sclerosis drug. The list price of brand Tecfidera in the first quarter of 2021, excuse me. Sorry, I got a kid in the room. The brand version of Tecfidera was $8,300 in the first quarter of 2021. After 10 months of competition, the generic cost had gone down to $184 per month. So anybody in this room could do the math here, right? $8,300 list price for the brand, $180 generic. We should be covering that generic, right? Well, that's not what happened. When you look at Medicare data, it shows that over half of seniors were enrolled in Part D plans where their PBMs forced them to continue buying the brand version despite a generic version that was $8,000 below the cost relative to that list price. 39% of seniors were enrolled in plans that at least gave them a chance, but heavily incentivized them to continue getting the brand. Only 8% of seniors were enrolled in plans where their PBMs actually mandated the coverage of the generic over the brand. Understand that even though there might be rebate dollars that make this reality different, the patient is paying in a deductible where they're paying off the list price of these products, which means they're shelling out for the expensive brand version when the generic is, metaphorically speaking, collecting dust on pharmacy shelves. We believe that you need to look at rebates as what they really are, which is money from sick people. When you walk into an appliance store and you buy a dishwasher, okay, let's say you walk up to the counter and it's $1,500 and there's a $200 rebate associated with it. When you walk up to that counter, you pay the $1,500, you fill out the form, $200 comes back to you. If that doesn't come back to you, somebody took your money, you were overcharged. That's not how it works in the drug supply chain. If you are a sick patient and you're taking insulin or any drug that has a rebate associated with it, you walk up to the pharmacy counter, you pay a bogus inflated list price, and then the negotiated rebate, that goes to somebody else, whether it goes to lower premiums for other people, whether it goes to PBM profits, whether it goes to the employer, whatever it is. The system is already designed with this intentional trade-off in mind, that high list prices create high rebates that don't end up always going back and full to the end payer. Now, back to the generic side and some of our discussion around pharmacies. In the drug supply chain, pharmacies rely heavily on what PBMs negotiate as the end cost at the end of the transaction. We did a study in the state of Oregon where we took 15% of all the pharmacies in that state and then looked at the rates of reimbursement for those products, or the prices that were being created at the point of sale by PBMs. And we essentially boiled them down as if they were 100 claims. What you can see here, for those of you who ever talked to a pharmacy owner who's complained about how the system is working, you probably have seen and heard about the drugs on the left side of this chart. These represent underpayments. So this chart has a red dotted line that goes across the bottom. All right, that essentially represents when a pharmacy breaks even on a transaction, meaning they bought a drug for $5, they're paid $5. So the first percentile of claims off to the left here shows essentially the worst case scenario for the pharmacy. As you can see, there's a red bar that goes below the red dotted line. That signifies about $100 underpayment to the pharmacy. They bought it for $100, they got paid $100 below that acquisition cost. The next patient walks in, $30 loss. Next patient walks in, $50 loss. And as you can see, the pharmacy is essentially adding losses over time. Not until they hit the 18th percentile are they starting to dig their way out of the hole. And then you move all the way to the end of the chart where pharmacies start making a lot of money. Let me explain. In the drug supply chain, and based upon our Oregon study, 18% of all pharmacy claims are paid below the actual cost of the product, meaning the pharmacies are not even making enough money to break even on the drug itself. Pharmacies don't hit profitability until the 75th percentile of claims, meaning they've made enough money to dig their way out of the hole that was created by those underpayments. The thing that I think is the most messed up about this is that 5% of pharmacy claims are responsible for 62% of their total accumulated profit. All right, so that long end of the tail off to the right here, all right, this represents where pharmacies are making the most amount of their money. Those drugs tend to be specialty products. Those specialty drugs are typically dispensed by pharmacies owned by PBMs. So if you're sitting there saying, okay, Antonio, this was confusing, but I think I get it. Maybe spread pricing can be harmful. Maybe these rebates are a big distortion. Maybe we need to do something about those. Just when you think you have the answers, they're changing the questions. This is research from Nephron, which is a Wall Street analytics firm that actually parses out where PBM profitability occurs across lines of business. The bottom two parts of this chart are rebates and spreads, so the dark blue and the light blue. As you can see over time, PBM profitability and reliance on spread and traditionally named rebates have been eroding over time, where today they make up less or just around 20% of overall PBM profitability. Today, PBMs make the most money on loosely defined administrative fees to contracting entities and those rebate aggregators that I explained earlier, but they make the most money on specialty drug fulfillment or specialty pharmacy, which is the fancy phrase we use for dispensing specialty drugs. So the companies that we rely upon to lower the cost of medicines are making the most money on the most expensive medicines that they control. So the question is, what makes specialty drugs so special? When I talk to plan sponsors, they say, you know what, this is all interesting, but you know what really bothers me is specialty drugs. So rebates, spread, we got that under control. Tell me about specialty. Well, let's look at those specialty drugs. What we did is we downloaded every specialty drug list for the big 3 PBMs and simply asked a very simple question. What is a specialty drug? Well, when you look at the different drugs on each one of those specialty drug lists, more often than not, the big PBMs disagree on which drugs are specialty rather than agree. Here's an example with Optum. Again, this is publicly available information. What you can see on their specialty drug list, an overwhelming majority of the drugs on that list are actually generic drugs, not expensive brand name products. So this is a study that we did in Florida, looking at some of these perverse incentives of PBMs. PBMs, when they own the dispensing pharmacy, the drug costs are more expensive than when they're being dispensed outside of traditional pharmacy. So in the state of Florida, we looked at every drug that was dispensed in their Medicaid program, and we looked at which pharmacies they were being dispensed at. 80% of all prescriptions for brand Humira, which is the hottest selling drug of all time, the biggest complaint point of employers from our experience and Medicaid programs. 80% of all the prescriptions for Humira were filled at pharmacies owned by the PBM. Only 20% were filled at pharmacies not owned by the PBM. For the 4 largest plans in the Florida Medicaid Managed Care Program, it was more expensive when Humira was dispensed at pharmacies owned by the PBM relative to the typical traditional community pharmacies. That's because PBMs have an obvious perverse incentive. They are the price setter and the price taker when a drug is being dispensed at a pharmacy they own. In Ohio, after they banned spread pricing, pharmacies across the state called me singing my praises because they were making more money on prescriptions than they did before. Well, which drugs were they making more money on? Specialty drugs. So since PBMs create specialty drug lists and they can dictate where patients get their medicines filled, PBMs love to create very aggressive payment rates on traditional medicines they don't fill. But when it comes to medicines that they typically dispense out of their own specialty pharmacies, they all of a sudden find their kryptonite and all of a sudden start getting the least competitive rates that you can find in the marketplace. When pharmacies in Ohio were celebrating the return of profitability, we found that a majority of the drugs that had experienced big price hikes were the drugs that were predominantly dispensed at PBM-owned pharmacies. So independent and community pharmacies were getting some crumbs off the table, but PBM-owned pharmacies were in fact helping themselves to the buffet. To give you a sense of how significant this is from a competitive perspective, all right, let's not even think about the PBM. Let's just think about the pharmacies. Back to our study in Oregon, we had 15% of all the pharmacies in the state of Oregon who voluntarily hand over their data for the purposes of our analysis. We compared that to what the Oregon Medicaid program was being charged. For generic Tecfidera, one of the most expensive drugs that they were paying for in that program, generic Tecfidera had a list price of $350 per prescription. What did we already talk about with list prices? List prices are bogus, inflated, and not reflective of reality. Despite a list price of $350 per prescription, the state of Oregon was being charged nearly $3,000 for every one of those prescriptions, meaning that's what was actually being paid by the Oregon Medicaid program to PBMs to then pay pharmacies. Well, that profitability is significant. The typical Oregon pharmacy yielded only $7 in margin for every transaction that they dispensed in the Oregon study. So the profits that were being amassed on generic Tecfidera were so significant that they were equivalent to a regular pharmacy filling 1,011 prescriptions of everything else. So you could fill one generic Tecfidera prescription and it's equivalent to 1,000 prescriptions of everything else. And big surprise, out of the 15% of pharmacies that participated in our study, not a single one of them got to dispense this drug. To size this a little bit more, we did an analysis of small employers throughout the Midwest, and we simply asked the question, are PBMs giving a good deal on generic specialty drugs? We drew an arbitrary line at $1,000, and we said, okay, let's look at all the drugs that are less than 1,000, all the drugs that are more. We asked, okay, are PBM-owned pharmacies filling a lot of these? Well, for the cheap generic drugs, PBM-owned pharmacies only filled 11%, whereas for the expensive generic drugs, it was over 51%. So very clearly, regardless of how it was being done, PBMs found a way to dispense more of the expensive generic products versus the cheap. So the question then is, are they getting a better deal? When PBM-owned pharmacies were filling the cheap generic drugs, they did so at an estimated profit of $26 per claim, which is over 2.5 times what a pharmacy needs just to break even on their overall operating costs. But look at the expensive generic drugs. Despite PBMs filling over 50% of the expensive generic drugs, when they did so, they paid themselves an estimated profit of $3,448 per claim. Again, despite a pharmacy only needing $10 in margin just to break even on their operating costs. One of the last things I'll show you is an investigation that we did with the Wall Street Journal in September of last year. Well, what we did is we looked at what large PBMs were charging in Medicare relative to the underlying costs at Mark Cuban's cost plus drug company. What we found was that for a lot of these specialty drugs, PBMs were charging 100 times more than what Mark Cuban was charging as a startup pharmacy disruptor in the marketplace. With that, I will turn it over to you. There's a lot more that I could go over, but I'll turn it over for questions.
Wow. Yeah, that's all I can say. Questions, go ahead.
I have a question. You talked about the vertical integration of drug marketing and sales. So what is the impact on, our focus is on state payers and state plans. What is the impact of that vertical integration on, for example, Medicaid, or does it cement these cost increases, or does it make it harder to parse out where the savings might be? It's confusing. I mean, the whole thing is confusing. But
So I'm a big believer in the philosophy of Medicaid managed care. The idea is to use public-private partnerships as an ability to try and create choice in a Medicaid marketplace that isn't just a top-down approach. So the idea of managed care is patients have choice to pick different managed care plans for their overall needs. The challenge, though, is again, understand these are not charities that are running these managed care plans. These are publicly traded companies who want to make more money today than they made yesterday. And part of the double-edged sword of the Affordable Care Act was the creation of the medical loss ratio. Under the ACA, essentially, they created a profit cap, if you will, on insurance companies, saying, look, if we're going to require all this money that goes to insurance companies by way of premium dollars, we need to ensure that a certain percentage of this is actually going to care. Because the old way of thinking about insurance companies was that you give them money and they'll do whatever they can to essentially starve the beneficiary of care, right? Health insurance companies can make more money by collecting in premium dollars and not actually spending it on care. So what they did is they said, look, let's at least create a standard and guarantee that no matter what, at least 80 or 85% of every premium dollar has to be spent on care. What that means is that you essentially have profit capped the insurance companies, meaning that they can only make essentially 15% based on what what's being spent. An obvious perverse incentive there is that insurance companies can make more money if they spend more money on care, right? They just grow the size of the pie so that the 15% yield becomes more money. Well, the other way that they can subvert the intent of those medical loss ratio requirements is to say, okay, well, if we, the insurance company, can't make more money, maybe what we can do is start buying up care providers. We'll start buying our own pharmacy companies. We'll start marking up pharmacy claims. We'll start buying up physician practices. Now we can move to other layers of the healthcare supply chain, if you will, where we have no caps on profitability. And the good news is, if we overpay our own affiliates, it also does the secondary benefit of growing the size of the overall pie. So from a managed care perspective, again, not to indict the philosophy of managed care, but I think anytime you're talking about the mixing of public and private dollars begs for transparency and accountability, right? The medical loss ratio was one way with which we were intended to try and create transparency, or at least accountability, maybe not transparency. But I think that state Medicaid programs, and not just Medicaid programs, but state public employee funds, state retirement systems, everywhere where public dollars are being spent, begs for a significant amount more scrutiny, recognizing the conflicts of interest that vertical integration has created.
Senator Rosenwald.
Thank you. First, I have a comment. Thank you. Great, very interesting. So I am a participant in the state plan. And in January, I filled 3 90-day supplies of old generic drugs. The claim was for $892. Between what the plan paid and what I paid was $1.91. Now, I'm pretty confident that somewhere in there, Anthem's PBM Carelon is making more money somewhere on that. Maybe it's which product they put on the formulary, whatever. I don't know, but I just think that for $892 worth of a claim, even though that's inflated, $1.91 is not the end of the conversation. But
100% correct. For any claim, from a pharmacy perspective, let's just use the pharmacy as an example. Pharmacy is going to be paid based upon 2 buckets. What did the patient pay? And what did the plan sponsor pay? Those combine to create the net experience. So sometimes you as a patient, I mean, many patients will hear like the phrase drug affordability and say, I don't have a problem, right? Because they have a $0 copay or a $5 cap on a copay, right? Or maybe they're not taking a medicine that lends itself to high cost sharing, right? It's just, a lot of people may not experience the drug affordability crisis that we tend to talk about. On the other end, sometimes when a patient might pay very little, there might be something else happening on the other side of that transaction, which means the plan sponsor might be shoveling in more money than they should. Impossible to know, with your scenario, but I think rather than guessing, saying, hey, like something is awry, right? I usually like to say the old phrase is trust but verify. The drug supply chain has earned no trust from top to bottom. My philosophy is distrust and verify again.
well, I sort of figured there's more money changing hands somewhere, and on specialty drugs, maybe the plan is paying a lot more. But my question is, I know that the US Supreme Court said that Maine's law requiring the PBMs to be fiduciaries was unconstitutional. Are there any states that have negotiated voluntary fiduciary agreements with PBMs or PBM aggregators rather than requiring it?
So, PBMs, I believe, can be fiduciaries. I think there was a problem with the way the main law was being constructed. And without taking stance on like the legal side of whether or not a state can mandate a fiduciary obligation on PBM, right? But the concept of a PBM acting as a fiduciary can be done. In fact, it's part of the intent, I would argue, of the Consolidated Appropriations Act is to extend plan sponsor fiduciary obligations to that PBM. There's a big lawsuit here at the beginning of this year of a patient of an employee of Johnson & Johnson who argued that Johnson & Johnson violated its fiduciary obligation to its employees as a self-funded benefit plan. And the nexus of the complaint is that Johnson & Johnson's PBM was engaging in price manipulation that worked to the detriment of the beneficiary. Without taking sides on whether or not that's true or not, I think that the philosophy that is being argued is that if a plan sponsor has to act as a fiduciary, then the question then is, does their vendor have to act as a fiduciary to them as well? Or are they automatically out of alignment of their obligations under ERISA? I participated in a panel in DC a couple of weeks ago with James Gelfand, who's the CEO of the ERISA Industry Committee. They represent some of the largest self-funded plans in the country. He was making this argument that how can we as employers be required to be fiduciaries to our employees, but not have that same obligation extended to the vendors who control our pricing experience in pharmacy?
Thank you.
What data do we need to be able to parse this out and have the level of accountability that you provided to Ohio? In other words, we're the PDAB and we're trying to understand what are the actual costs, especially to the taxpayer, which is, that's our mission. And then we make recommendations. So what is the database? We have access to things like CHIS, we have access to other federal databases, but is that enough?
So I'm happy to provide a document as a follow-up to this committee with all the data fields that we request on behalf of when we do work for state attorney generals, state auditors, plan sponsors. It essentially has all the fields that are required to do a comprehensive analysis of pricing experience. Now, ultimately, that comes from the PBM itself. I want to stress this. A lot of what you heard me talk about today was very PBM focused. What I'm going to tell you that you need from a data perspective is going to be very PBM focused. There are other things that you probably could look at beyond the PBM, but understand that the over focus on PBMs is a direct result of the way that the system is designed today. We know drug companies want to make more money, right? We know they sell to wholesalers who want to make more money. We know that they sell to pharmacies who want to make more money. We invited PBMs to the party to negotiate our experience against one end of the supply chain that wants to make more money. So the PBM is designed to be that friction point for us as the end payer. So ultimately, the itemized accounting has to originate with them because we're never intended to pay the bogus and inflated prices that the other end of the supply chain is already creating.
Hey, thank you. This is a very deep, very thick topic, and you did a really great job, I think, of laying it all out. As I was looking to your point about this being a very PBM-centric view, I'm just curious, what part of the pharmaceutical costs are we not looking at if we only focus on the PBMs? I thought here in New Hampshire, we may be looking at just about 50% of our total government spend being, PBM related versus non-PBM related. What's your experience? How would you describe, what a PBM centric view does to the pie chart of total government spend?
I think it's a fantastic question, right? And it gets to, again, I think the fundamental question of what it is you want to buy and what the value of that is. I would argue that drug companies are bringing in a lion's share of the amount of money that are being invested. If you look at public facing, even public facing information that the industry association puts out, right? They would argue that they're making less than half of around all the dollars that are invested in the drug supply chain at this point, but it's around half, right? So if you break out all the money is going, I think you will still find that from a proportionality perspective, drug companies or brand name drug companies are still bringing in the highest amount of revenue. But I think it begs the question at that point of back to what I said at the beginning, and I'm not trying to say where we give drug companies too much or too little, right? But at the end of the day, we're trying to buy more innovative therapies, right? We understand that we as society will have to invest more and more to get those. To me, where accountability lives with drug companies is, are we getting a good value for those drugs? To me, a lot of the drugs that we see that are coming to market, many of them I think are high value. There are others that I would look at and say, non-clinically speaking, but knowing enough, that those are drugs that are not worth investing in. They're follow-on products that have very limited value relative to their predecessor products. Again, those aren't my decisions to make. That's ultimately what formulary design is supposed to be for. So again, not to push it all back to the PBM, but we use the PBM to act as our agent to determine which drugs are worth covering and which ones aren't. What is the value of those drugs relative to their underlying cost? Unfortunately, so much of the decision-making process of which drugs end up getting covered and thus create money for drug companies end up being decided by companies who are getting kickbacks from those drug companies. So we have a very distorted agent and conflicted agent who's ultimately making the decisions on which drugs get covered. That ultimately determines which drug companies are getting your money and how much of it they're getting.
I appreciate the answer. I'm guessing that I didn't phrase my question very well though, because I didn't hear, I was expecting a percentage of some kind. What percent of the government spend, you think at a state level like Ohio, was PBM related versus all other?
Got it.
I think, Antonio, when we look at our drug spend here in the state, we're now hitting approximately 51% of the drug spend is in the medical benefit side versus the PBM side, and the medical benefit side may not flow through the PBM side.
Got it. I don't have that percentage. That's not an analysis that we've done. Versus medical versus pharmacy, if that's the nature of the question. I'm not familiar with that breakdown.
Thank you. I think it's great that he says he doesn't know the answer, because I don't know the answer. I know it's a lot of money that we are spending from a government perspective in other areas for drugs that are not PBM related.
That's correct.
And I just want to make sure that when on all his slides, it says, this is how the system is supposed to work. But that's in retrospect, that's the PBM system, not the drug market systems.
Correct. I think if I could, is the fact that when you look at the overall market, you get PBMs working through pharmacies, but you also have medical providers that are also billing the insurance companies through the medical benefit side versus going through the prescription medical side.
Yeah. Thank you so much.
Absolutely.
Tony, if I could, first of all, it's a very in-depth and very informative presentation. I'm a strong believer like yourself in a sense of how do we take the market forces to do what the market forces can do to create that friction so that we have the ability to not micromanage the market, but try to unleash the forces of the market itself to do what it should do.
So great question. From a policy perspective, beyond what I think could be accomplished at a state level, I'm a big believer that the exemptions that were made to anti-kickback laws were undeserved and had backfired significantly. The opacity of the marketplace and the amount of arbitrage that can exist off $300 billion in spend of rebate dollars is just massive. And you just have to trust me when I say I've seen enough PBM contracts with plan sponsors to know that pot of money is not going where it needs to go. Furthermore, what it does is it creates an environment where drug companies don't have to compete on price. If you look backwards at insulin, despite having significant competition in the insulin sector, over that time period, insulin prices actually rose rather than decline. That's a problem. The net cost of insulin actually got grinded to the bone over a 10-year period, meaning that it was hundreds of dollars down to $35 a vial, roughly between the three different insulin manufacturers. Yet the list prices were hundreds of dollars. So that's a good demonstration that in real markets, traditional markets, competition works to improve quality and lower the underlying price of something. When you allow for a system of kickbacks, it does the opposite. You have prices go up, entrenched entities able to protect that market share through those kickbacks, and now you're operating off a higher sticker price that everybody else has to try to get a better negotiated experience off of. I don't know what you can do there, okay? But beyond that, I do look to what's happening in the cash pharmacy marketplace as a good hint as to what's possible. We get 87% of all pharmacy claims are generic drugs, okay? That means 87% of people that are out there at the pharmacy counter are getting generic drugs. Well, why are we insuring a deflationary asset? Generic drugs are designed to go down in cost over time, yet we provide insurance for them. We don't buy insurance for things that are degrading in price. We buy insurance in other marketplaces for surprises of high costs. That's what insurance was supposed to be. And I would argue that the philosophy of insurance is tailored specifically to handle brand drugs, but I question why we throw 87% of drug transactions under an insurance benefit. That's because we don't have insurance anymore. We have managed care, where a health insurance company, or at least what we used to call a health insurance company, is managing our overall health care. Well, the beauty for them is the more they manage, the more they get to charge for that overall management. Spread pricing was largely a generic drug phenomenon. Despite the actual cost of many of those drugs being less than $10 a piece, PBMs were charging over $6 in spread for every one of those transactions in Ohio. So meanwhile, you walk into a pharmacy, what do you see? The sticker prices are bloated and inflated. Why are they bloated and inflated? Because that is the starting point for their negotiated experience with a PBM. When you unplug from an insurance-based model, then you see a very different reality. You have Mark Cuban's Cost Plus Drug Company, which doesn't take insurance. Here in Ohio, we have Pickerington Pharmacy. It's an independent pharmacy where the owner decided this isn't working anymore. So I'm going to open a new pharmacy right next door. And so here in Pickerington, Ohio, you have the same pharmacy, the same pharmacist that owns two businesses that are side by side. One is Pickerington Pharmacy, where he serves insurance and PBMs. The other is Freedom Pharmacy, where they don't accept insurance and they charge a set, transparent rate to every patient that walks through the door. The same guy is buying the same drugs, okay? But in the insurance-based pharmacy, the prices are exponentially higher than at the cash-based pharmacy. To me, it's a good example that if you insert more traditional market forces and greater consumer-based pressure on the prices of medicines, you can achieve a much greater environment for price than you do in the system of today, where we have to rely on a negotiator to insulate us from bloated prices that they help create.
More questions? Good, I see a commissioner's here as well, so. Antonio, thank you very much for this today as well, and I thank you for sending that data field. I think it's gonna be important for us to understand what we need for data fields to begin to look at some sort of analysis if we're gonna move forward in that direction. It's been very insightful for what you provided to us today, and I think it's been very helpful to the board for future discussions.
Thank you so much for having me. Happy to answer any further questions.
Do we have his contact info?
Yes.
I might call you later.
Thank you.
Embarrass myself in public.
Bye-bye.
Thank you, Tony. Next, we could, Commissioner Davenport. You wanna step forward? And On the agenda, we'll talk about the redundancy report. I want to say thank you to the insurance department for creating it and having this conversation with us today.
Well, it is my pleasure, everyone. Good morning. For the record, my name is TJ Betancourt. I have the pleasure of serving as the commissioner of the New Hampshire Insurance Department. As you know, we were asked by the legislature, I believe somewhere in House Bill 2, to undertake a redundancy report on the work that is taking place here. While I always, of course, take responsibility for the work product of my department, I must recognize and thank Dr. Azaz and Morgan back there for their considerable work in putting this together. Also joining me today, who put in a lot of work into this report, is Jason Dexter, our soon-to-be assistant commissioner, but at present, at least until Wednesday, he is the head of our life and health division. So I want to reserve the bulk of the time to answering your questions, or more appropriately, having Dr. Azaz answer your questions in whatever detail you'd like. But I'd first like to start more generically in terms of what the department is doing, and then highlight some of the key findings within the report, if that makes sense. So one thing that I want to be absolutely clear about is that the New Hampshire Insurance Department shares this board's commitment to transparency. That has been a principle of the department for a very, very long time. It really stretches back to the creation of the New Hampshire Health Cost website, which, when it was launched in 2015, was the first website of its kind. And since that time, we've obviously sought to evolve and to grow what we do in fulfillment of that commitment. One of the benefits that the department has is a strong authority to collect a large share of data that can inform this board's endeavors around price transparency efforts. So if this board decides to consolidate its data and data collection authority to the department, we will take that responsibility obviously very seriously, and will be transparent and a good partner with all of you, as well as all of the other state policymakers who have a passion in this space. In terms of our current activities, because as I said, we are constantly pushing ourselves to do more and to evolve. We are looking at high cost prescription drug dashboards, which is our charge in RSA 318:68. We are looking carefully at the prescription drug cost and utilization reporting, which is delineated in RSA 126BB9. And we are also collecting and reporting on PBM total drug expenditures and rebate data pursuant to RSA 402N:6. And I would note, and I'll come back to this again later, that contained within Senate Bill 555, which those of you who are senators here, Senator Rosenwald is familiar with that piece of legislation. It does a couple of different things, but among the more impactful, but not necessarily controversial provisions of that bill is language that will strengthen my department's ability to collect precise data around PBMs.
To that point,
Yes,
may
sir.
I, Mr. Commissioner? This report doesn't anticipate that that legislation going into effect, right? I mean, if that legislation went into effect, that might be another area that would go into your recommendations.
That's right. So just to kind of back up for one step, as you know, or as I referenced before, we were asked to do this report in House Bill 2. I believe that our deadline per House Bill 2 was actually to come before this board in the fall.
Right.
But Dr. Azaz had said that there was a great deal of interest amongst many, if not all, members of the board to bring forward what I would classify as an interim report, if you will.
Right.
And so that's what I'm here to speak to today. But certainly if that legislation were to go forward with those provisions, then that would be factored into what I think is going to be kind of the final report, which again will come to you in October, November, whenever you'd like to have us come talk about that.
Thank you. I appreciate you taking
Sure.
the interruption.
No problems at all. So as an adjunct to RSA 402N, again, Senate Bill 555 aims to fortify the department's data collection authority over insurers to report prescription drug rebate enumeration. As you may recall, when the current PBM arrangement was first put into law, I want to say 3 or 4 years ago, it obviously dealt with where rebates are to be applied. What it did not include, unfortunately, and what has been of great irritation, I think, to my team, is that it didn't provide us with the teeth that we needed to go and get the information necessary to be able to report back to policymakers and to all of you, really how things were playing out. How things were playing out with those plans that decided to have those rebates applied at point of sale, what the impact of it was in having those rebates folded into premium. We didn't have that. We obviously want to avoid that phenomena this time. And so that has been our involvement in terms of Senate Bill 555. Where the legislature ultimately decides the rebate should be applied or what flexibility there should be around that is obviously a policy decision that the legislature will make. But to the extent that you are looking to our department to be able to provide to you substantive data on how that's going, we're going to need those tools. Yes, Senator.
Sorry,
That's okay.
I just had a quick question. Based on the presentation, which hopefully you saw this part of us, it seems like what PBMs have done elsewhere in the country, and I don't know if they're doing it here, but they have now reclassified the rebates. And they've created companies that actually handle, you probably saw the whole columns, the 2 columns on the right. So they're, and I can't remember what he called the companies, but they created these companies to actually, I'm sorry, what?
Rebate aggregators.
Aggregators.
Alligators.
Is 555 going to give you the capacity to look at the whole picture with PBMs?
We certainly think so. We certainly think so. I mean, part of my frustration in reporting to, when I testified before the Senate Health and Human Services Committee, when they asked me, how is this all going to play out? And I said to them, I have a wholly unsatisfying answer. I don't know. I don't know how the market will correct when you start dictating where those rebates must be applied. And I think that what that presentation showed you is, yeah, there could be some very innovative, creative ways around getting around the provisions foreseen in Senate Bill 555. In addition to what was articulated in that presentation, you could see folks get rid of rebates entirely. We just don't know how all of that is going to play out. And I think that was a detailed presentation of why we're feeling that uncertainty.
Thank you. Thank you for being here. Does the insurance department have insight into the rebates that Medicaid is getting or that the Department of Corrections might be getting through? They do some work with 340B, but not their entire drug spend,
I believe that
or
we do.
just
Yeah, so,
the
Dr. Rez, you wanna take
commercial
this?
market.
yeah, so the Senate Bill 555, I think, has 2 domains. The first is aims to strengthen the insurance department's ability to collect total drug spend from PBMs and total rebate data. So that would include all drug spend in the state. So that would include the population you just mentioned. I think it's, there's not any one data set that captures the whole picture. And that's one of the interesting parts for strengthening our authority to collect more granular data from the PBMs, including the rebate data. Recall that we also get the claims data, which again, in of itself isn't holistic for all markets in the state, but also is a good sample to give us a sense on both sides, the prescription drug benefit that's usually managed by the PBMs, but also, as the chairman said, the drug spend and the medical claims data. So the goal with taking together all of these data sets are to, improve the transparency for all of the drug spend in the state, because there's a lot of different secular components here.
And if I follow up, well, given that list on the right-hand side of the slide of all the things that are not called rebates, but are monies that the PBMs and their higher level aggregators take does the language of that bill, which may or may not go anywhere, does it allow you to collect the entire amount of money that's being taken by that part of the supply chain, or just what's termed a rebate?
It's hard to know the latter part, the answer to the latter part. What can be useful is to look at the total drug spend. How much in the state of New Hampshire do the people spend on drugs? From there, you can look at it in a lot of different ways.
But which people? I mean, I think Antonio made the point of who's the person we're interested in. The way I read this chapter is that we're talking about the state payer. So for me, that's Medicaid, the state plans, and
The
corrections.
hope before we interpreted this report was to have the chair go over who the public payer is. I think that's ill-defined in the statute because that's at odds with how I defined it. The state, the public payer in 126 BB, under my assumption was the state employees, University System of New Hampshire, the School Teachers Association, and the municipal payers.
So not corrections and not Medicaid?
Corrections, but not Medicaid in the other public payers, but that's the first order of business this board should clear up before.
Correct.
Before we start looking at the right data set to perform that.
As the prime sponsor of the bill.
Yeah.
The intent was to cover all taxpayer costs related to health coverage. And so that would include Medicaid. Should have been more specific in the original bill, and we could certainly clean that up through legislation.
Yeah, and thank you for adding that. Would be my hope that the final report should reflect that and be very specific on who's in and who's out on that, because the data authority that we should strengthen and on that front should reflect who we have regulatory authority over.
If I could, in Senate Bill 555, which I believe is about the rebates,
Mhm.
and given the fact what I just heard about redefining what a rebate is and working off the wordsmithing, is maybe having the insurance department go back and look at that slide and saying, does the language in Senate Bill 555 give it broad enough to collect all the other things we're talking about here? Because if it
It
doesn't,
just says rebate.
if it just says rebates,
Mhm.
and we know how rebates can be reclassified in many different ways, then we want to be sure that we can capture as broadly as possible the money that's flowing between the manufacturer and the PBM, so we're not at that point in time limiting ourselves.
I
Can
was.
I ask another
Sure.
question? Thank you. The information on rebates, which I think we now know is not all of what a reasonable person would say is a rebate. Is that product unit specific, or is it in the aggregate?
We would be able to.
Yeah, it's-
And do we have
The
access
current-
to choose?
The current reporting requirement for rebate, which is in our statutes defined as price concessions, which is broader construct and covers about half of the bullets in Mr. Chacha's list. But could maybe use even more refinement. But it's at the aggregate form now, and I think one of the line items in Senate Bill 555 aims to make that more granular at the product specific level. If it ends up becoming law that way.
Yeah, and what I would say is, obviously, how this data is presented is the source of considerable attention and for good reason.
Mhm.
What we certainly, I think, with 555 certainly contemplates is aggregated data or as detailed data as possible without running afoul of proprietary information. We obviously don't want to find ourselves bollocksed up in lawsuits because PBMs and others are feeling as though we're giving away what Chairman Hunt nicknames the secret sauce of how they do their business. But we at the department will obviously have that, have all those recipes we will have that data. And we will be able to, broadly speaking, give you a more detailed understanding of how all of this is playing out.
But I'm sorry, will you have it for Medicaid and corrections as well?
So in the claims data, about 92% of the Medicaid spend is in the claims data currently. We have, a memorandum of understanding with the DHHS, so procuring the other 8% of the Medicaid fee for service is probably achievable.
What about corrections? Because that's a big spend.
Yeah, I mean, those are in the CHIS, so a lot of the state self-funded plans are in the CHIS. In fact, both.
Well, not on the employee side. What about the residents? I heard that. Inmate side.
You know, I'm not sure about that.
That would be really helpful data because it's not covered, a lot of it's not covered by Medicaid and it's paid for by the state tax.
Well, in
Could I-
Red
could
Veterans, I know
suggest
that they
that
double
Dr.
the
Sherman,
cost.
You and Dr. Aziz, look at some of the detail to make sure that the intent of that original bill is actually, manifesting itself in the list of government payers. Because it looks like Dr. Aziz and the department could use a little bit, more interpretation around that, as long as we don't go outside the lines of the law.
Yeah, what I would say is you guys set the parameters and we'll go to the best of our ability to get you the data. You give us the direction and we'll use the tools that we have to go out and get that for you. I mean, I think this current conversation dovetails perfectly into the next bullet point here on my list, which is we are constantly trying to improve our CHIS database, to be able to get more data, to be able to get more information, to be able to provide you with the best and greatest context possible. And we're constantly pushing ourselves to do that work.
Before you get to, I had another question, and I think it's related. I don't believe we have currently a comprehensive list of data submitters. In your executive summary, it says, sort of in the midpoint, data submitters are defined in the report and then in the italicized, insurer, PBM, and drug manufacturer levels. And so I don't, if you're gonna go out and collect data, you have to have a laser clear precision on who you expect to deliver the data. And I don't know that we've gotten to that level of organizational maturity yet.
Can I add just to what you just asked? Is that okay? There are some people missing in that threesome there. There's the wholesale, the pharmacists. So he had a really nice list that was very comprehensive. Can we make sure that you're getting all of that data too, if you're doing this?
Yeah, collection of data requires statutory authority. So, I mean, if you look at 46 Brooklyn, that they use free public source data.
But one of the things that I do concur, I think part of it is, what do we need to collect? And then how do we collect it? And then from whom do we collect it? And I think part of what I'm trying to get to is that if we don't have okay to have the authority, but if we don't have to enforce that authority, then we don't have authority. So the question I'm trying to get to is, in SB 555, there's a requirement for report stuff, but is there anything in that bill that the person who's supposed to report something, if they're not compliant, how do we enforce compliance? Because if we can't enforce compliance, then basically we're not gonna be able to get the data.
Sure. Well, contained in that bill specifically is a provision of a $10,000 fine per violation, should the information not be turned over. And I can assure you that that adds up quick. Our default standard in most of our enforcement mechanisms at the department is $2,500 per violation. And I can tell you that when we unfortunately encounter enforcement actions, that $2,500 adds up really fast. So I think that there's a strong incentive there to ensure that we're getting what we need as required for them to provide us under the statutes.
And also, once the data is collected, what's in the statute to allow that data to be shared with other entities, including the Affordability Board and the Department of Human Services? Because we don't have the ability to share the data even though you're collecting as an insurance department, then we're sort of at loss, because we don't have the way
Sure.
to analyze it.
As I said before, I mean, Dr. Raz can drill down on this. What I would say, again, broadly, generically speaking, is we will share with you everything that we can without violating proprietary protection.
Do we have to go back to SB 555 to ensure that we have that ability? Because some of it will be proprietary, that's why we put in the bill and talk about confidentiality. And the fact that if we were to share any of that data, there was it's a criminal penalty. So what I'm trying to get to is how do we ensure that we can eventually get to that data so that people can start analyzing it to do what we have to do?
That's a difficult question, because if you're gonna start requiring them to turn over data that would be defined as proprietary, then there's gonna be a legal backlash.
Well, just the original bill, and this has been pulled out of PDAP, we had the ability to receive proprietary information and to analyze it. We could not release it. It had to be released just like you're talking about. So it'd be interesting to go back and revisit what level of access we have to your data. Because we don't want to be doing the work you're already doing, and I think that's what this report is talking about. But we do want to be as smart as possible and as well informed as possible, so we can make those recommendations. I'm sorry.
No, it's fine. I haven't actually forgotten what I was gonna say. And the database, do we have any flags to indicate which data elements or which data segments would be proprietary versus less proprietary, so that we know where the sensitive spots are? And is there, or should there be some kind of due process to help the providers of the data ensure that they know what we consider to be their proprietary data, and for them to contest it if we miscategorize it? Should there be, I don't think there is a due process for them to reclaim a request, and should there be?
I don't believe that there is, formally anyway.
Yeah, right now, the PBM total drug spend and rebate data can only be disseminated by the commissioner in this aggregate form. So we can't disaggregate it at the product level right now, unless something were to change by statute. And so that's designed to protect confidentiality.
Is that something that, as Senate Bill 555 worked its way through and talked about modification, because eventually if it gets to the Senate, we can deal with some modifications on the House side? I'm just thinking this through.
It's on its way to them.
It's on its way? Oh, thank you.
So
He's off the hook.
So to
Yeah.
follow
On
up
you
on
now.
that, the aggregation of the data is in fact a decent way at a strategic level to protect the data. I'm just wondering if we need more at the data level to identify which data specifically is sensitive.
So recall that in the claims data, we get that same information, but it's at the individual claim level. So part of this, as I was trying to mention before, none of it sits on its own. You can use each of these data sets to reconcile to see if we can account for the total New Hampshire drug spend in the claims data. And, so depending on what level of claims we're looking at, we aim to do that. We're working on strengthening up the CHIS so we can see more details in the medical claims drug spend, because Mr. Williamson reached out, and we identified an opportunity to improve the fidelity of the NDC drug code data for the medical drug spend. And so trying to put those all together gives us a more clear picture of the total drug spend and the total activity of drug utilization in the state, and trying to, get closer to the true value. No measure using data ever gets the true value. You can only hope to get the most precise estimates of the true value. And that's what we're aiming to do with these multiple domains of data that we currently have authority to get. Yeah, Dr. Sherman.
So suppose in looking at the data we are able to get from the department, we see an outlier or a group of outliers. And we go back to you, and you're part of the board anyway, and we all say, boy, we need to look at that in more detail. We're getting toward that potential threshold of proprietary data, which we won't have access to, and we may not be able to answer the questions of why is this specific outlier so expensive to the state, to the taxpayer? Is there a process, and I guess this is kind of what Representative Edwards was asking, is there a process for us to get a hold of that information so that we can understand what is happening, whether it's a rebate, whether it's that it's going to shell, I call it a shell company, but the other company that's been set up. Why is the taxpayer having to pay so much for that specific product? Which originally we had the capacity to do that, but we've lost that capacity, and will you have that capacity?
Yeah, I'd like to point all of your attention to, 3 of the prescription drug cost and utilization dashboard we now have on the insurance department's website. It might be interesting to you to see how we stratify and filter all the different reporting domains there. Because it probably answers that question you just asked. I mean, you could identify outliers right there. We hear Humira all the time. In fact, Mr. Chacha brought that up. You can see that the most expensive drug in the last 4 years, indeed the last 20, is Humira. So you can identify qualitatively your outliers right there. And that may answer a lot of questions that you have in terms of this ability for us to disclose it, because it's right there on the website. And it is probably a useful place for us to start. I think the purpose of Commissioner Betancourt being here was to try to encourage members of the board to, read the report. We can help you interpret it, but then offer some constructive feedback and commentary on how we can do exactly what you're talking about, Dr. Sherman. Make our, data collection very, very kind of homogeneous and not redundant, so that we can answer some of these important questions. I'll also ask other members of the board to consider what types of statutory changes we may need to make to clearly define who the population of interest is, and what other types of authorities we aim to procure to meet our mission.
Dr. Thank you very much, Commissioner Betancourt, for sharing your time and insight. I'd like to thank the commissioner and the rest of you guys for the help that you have provided in giving us data that we used in our final report. And congratulate the commissioner in including some of those results in your webpage. I noticed that the 100 most expensive by various categories. That classification, I think, I first saw in our final report, and look forward to this kind of interactive collaboration where we are involved in phrasing the specifics of questions, and then collaborating with you to some extent on data. I do have 2 concerns. One, the Axios article that talked about, the headline of which anyway was saying that these prescription drug affordability boards have been around for 3 or 4 years, but we don't see any results. My concern is that if we think of ourselves as asking you the legislature to pass the data that then you get collected, it'll be another 5 years before we get that data. I've been involved in the formation of CHIS. Actually, I think I might have actually done some of the first tabulations that went into the CHIS database, the cost database. And that was a long time ago. So I'm worried about the lag between finding or defining the data here that we need and getting some analyses. We are, as a PDAB, under the gun to get some results. And if our result is defining more data for you to collect, I think we will have failed. I don't think the legislature, as a whole anyway, will have patience enough for all of that to play itself out. My suggestion, and I'm very sensitive to this issue of confidentiality, that is really very important. And the industry in general will play games, so we need to be very careful with what we ask for and what we can get. As somebody that actually had detailed information on every prescription that every Medicare patient under the end-stage renal disease program had on my home personal computer, I'm kind of aware of what the issues are. I didn't actually have to promise my firstborn son, but it was very close. One of the solutions that I propose is that not that you share data on my personal computer, but you give me access to a keyboard. One of the difficulties with focusing on data that you've got as you are publicly reporting is that it's not, I think, going to allow us to do the kind of, we need to be focusing on not just Humira, but what the generics are in Humira. And that in order to do that, you have a good team that you've put together here. There, I would suspect not underworked and not have a lot of capacity.
I keep busy.
I have some insights. The question becomes, when you're doing these kinds of data analyses, you think you have your hypothesis and you start working on it and you drill down and you very quickly come up to what about? You see something this, but it doesn't explain something else. And it's not possible for me to write up front here are the runs that I want that I'm pretty sure can answer the questions. I am quite confident that any question that I put together will fall short of providing the answers. And the way to provide that is actually hands on a keyboard, where I would come in, or these days with the internet, there are all sorts of security. I just gotten into trouble with a machine falling out that had BitLocker that I didn't know about. So on your keyboards, in town, under supervision, in your offices, as I think a minimum of way you can say this data was secure, you can be assured of that, the litigation, but with access to the most detailed information, the most confidential, the most privileged.
Well, you actually are. We are, as members of the board, we are held, as we mentioned earlier, to criminal liability if we breach that. DHHS does have a capacity, which may be what you're talking about, for outside entities or for groups to say, we need access at a very granular level to your database. There's a process that you go through with DHHS. It would be great if for PDAB, there were a similar accessibility process that keeps us as PDAB members so that we have that same statutory accountability.
To clarify, are you referring to the Vital Records and Privacy Review Board that looks at clinical study requests for our vital records?
Well, not just vital records. I can't remember the
I think
database.
it's pretty much vital records. I don't know that they get beyond vital records.
They hold.
But I just wanted to clarify for them, so that when they go looking for an example, they find it.
So just add some color to respond a bit. We're committed to collaborating with you as much as possible. The constraint there, of course, is we can collaborate as much as possible within the scope of the law. There are provisions in New Hampshire law regarding confidentiality that if the department violates, or if I violate, I am personally liable. And we're doing okay, but the Bettencourt family budget isn't quite up for a criminal defense against a large corporation along the size of the PBM. So I will certainly give you what I can. And if there are adjustments to statute that are necessary, well, then that's gonna be a policy decision ultimately for the legislature. You had talked about PBMs and the general observation that a lot of PBMs in other states haven't had the type of success that was foreseen when they were created.
No, Prescription Drug Affordability Board, it's not PBMs.
Excuse me, PDABs.
Yeah, right.
A lot of acronyms going on.
Right.
I gotta keep them all straight for everyone. My general observation, and I totally get your point, as the great country band Alabama once said, you're in a hurry to get things done. And I get that. From my observation, where PDABs have not had the success that they were looking for, there were some common traits that, again, at least I have. One is that it got into a place where information was being siloed. They weren't having the type of collaboration that you all are having here with us, with DHHS, with others. Their mission was ill-defined. And I think that it's okay to adjust the mission, to hone the mission from time to time. But I think for the most part, you guys have a good sense as to where it is you're looking to go. And then finally, a lot of those PDABs tried to kind of recreate the wheel. And what I'm saying to you is, you've got a good mission. I think you're going to adjust the type of data you want and the manner in which you can get it. And obviously there are some parameters around that. But what I would encourage you to do is to leverage the department to help you get the information that you're looking for and not try to recreate that wheel. And I think that is the spirit in which this report is given. You know, there's no need to have the redundancies in the drug price reporting, the PBM, TPA, licensing and fees, and the drug rebate reporting. We have the skills and we have the ability to do that. Now, again, we're going to push the envelope, or we're going to do more. We're going to constantly evolve and improve. But we've got a good foundation there for you to work with. In terms of the data, again, insurer reporting, PBM reporting, drug manufacturer price reporting. Again, we've got a good solid foundation there. And we will get you what we can, and where we can't, then we'll see where we can improve our systems.
Can I ask one specific follow-up, which is, Dr. Chacha talked about a spread pricing as encompassing all of that two column on the right-hand side of that slide. Can you provide that spread pricing information now? That is, can the data that exists without additional legislation for a specific drug, my apologies, I'm not a pharmacist and I really had that hard time with it. The generics for Humira. Could you provide indication for the generics on Humira about what the spread pricing is?
I defer to Dr. Razis.
Not at the level now, no.
My worry is that you're in the move, in the direction of improving that data collection, but the PDAP won't have access to it for 5 years.
There's no variable called spread pricing.
I understand,
So
yeah.
Representative Merchant asked us to do a section of the annual report that may serve as a proxy for that, to look at biosimilars prescribed as, you know, eroding the branded biologic market. That may be a proxy to that.
One of your point about spread pricing, just so everyone knows, back in 2022, the Attorney General of New Hampshire settled with Centene for $21.8 million on spread pricing. So that was settled.
It's funding Medicaid dental.
There you go.
That's right. That's right.
So in saying that, to your point, it's a good one, is that I concern myself with what I call market adoption of biosimilars, and the industry is doing everything they can to slow the process down. Biosimilars is basically the same thing as standard generics, but it's in the biologics. Again, the more we can try to find ways to create that competitive forces in the marketplace, the better we're all gonna be, because that will bring down prices of competition. However, there is a bill that hopefully will get through the House, it's going over to the Senate, that the industry is trying to fight, because it's trying to encourage that, they are trying to discourage it. So maybe Commissioner along the way is getting you the bill to at least come to the committee and talk about, again, this is a ways for us to bring market competition down, create that friction in the market, and use the market forces to do things that we want to do collectively. Mr. Fahey, did you have a question?
I did not.
So
Could you remind me the bill numbers?
1365, and I'll get that to you as well.
Thank you. A lot of bills flowing.
Yeah. So,
Yeah,
yeah,
just a specific question on your recommendation. There are recommendations here that are talking about repealing section or and the data, though, is really important to us being able to make recommendations, as Dr. Woodward has pointed out. Would you consider going back on these recommendations and rather than talk about repealing, I would really prefer that PDAB were not in the position of collecting data. And it sounds like you're more than willing to do a lot of that data collection. And some of the data is already collected and available publicly, which hopefully we're going to get that list from Dr. Chacha. So when you're making these recommendations, rather than necessarily repealing a section, and this may be parsing, but I would ask you to consider going back to the recommendations and saying, rephrasing. Because the important part is that we are looking at data that includes that information, but we don't have to be the one getting it if it's available elsewhere, which is one of the things that I think is really a benefit of this report, is helping us understand that not only do you have the data already, you're looking at potentially expanding it and you're willing to work with us to expand it. You've got the mechanism for collecting it. And I think that's probably the driver of why we have a redundancy report, is to say, we don't need to be doing this. We can focus on the data sets that are available, ask for increased granularity or increased data. And that's why just under recommendations, going back and perhaps rephrasing it, I don't have the wordsmithing available right now, but
As you know, the term that's often used in the legislature is repeal and replace with.
right.
I'm seeing the repeal part, but I'm not seeing the part you're saying, and replace it with what?
Right.
And that's the rephrasing, I think, is to
That's what,
replace.
exactly, right. So
So it isn't you're against the repeal word, it's
No.
that you're looking for the
Words.
rephrasing word, which is replace with.
replace with, this is the data, or this is critical data for us. But we don't have to do the collection of it. It's already being done. So that's why I just want to make sure that we are capturing that. And sorry.
Todd,
Thank you. So to the point, I appreciate the reason for the redundancy report, and I think we as an efficient state ought to be mindful of unnecessary redundancies. I would just point out that sometimes redundancies can be helpful and often desirable. In many contexts, you want redundancy. And I'm not saying that in the case of reporting or collection that there ought to be redundancies, but to the point of my colleagues on the board, I do think a repeal is one piece, but to make us a more anemic body in the face of the many reports we've had from our presenters talking about how complex this is, I just think we ought to step back for a moment and think about it. If the Ohio situation has any resemblance to what's happening in New Hampshire, and the other states mentioned, that would be cause for outrage for taxpayers who are already burdened in New Hampshire, and for public payers, however we define them. So I guess in summary, I'm just saying to the point, we're going to think about repeal, I think we ought to think about what is the replace. And I don't know that we should be, I think we just need to bear in mind how Herculean the task before us is and how complex this is. Thank you, Mr. Chairman.
Yeah, to which I would say, again, if you give us the direction, we will do the very best we can to provide you with ideas on what the replace looks like. To Todd's point, there's a fine line, and you want to strike that fine line between being redundant and not being inefficient. To your point, you've got a very big task ahead of you, and you don't want to be burdening yourself down with things you don't need to be doing. You know, you've only got so much kind of bandwidth. You want to leverage that bandwidth to the greatest extent possible. So again, you know, we kind of threw some ideas on the table for you to consider. Again, this is an interim report. But obviously we've got half the year or so still left before this report is due in its final form. Dr. Azaz will be with you every step of the way. Provide him with the guidance and the direction that you want. And we'll do the best we can to fulfill it.
I have a big picture question for you. The original, I put this in the HB2, the redundancy report, and so my intent at the time was to take a look at the broader redundancies, and in your summary here, it points out that that this report is focused on the insurance department and the PDAB, the redundancy between those two entities. I had initially intended it to be redundancies with CMS or redundancy with the Department of Administrative Services or any other sort of redundancies that you were aware of.
Yep.
Is that too much of the elephant to bite off on by October?
Sure. So you and I had obviously talked about that, and I do think that there is value in understanding a larger picture. In terms of this report, with the time that we had to put it together, it just was not possible to begin that dive. We can certainly start down that path and see how far we can get come the fall. The federal government is vast and it is constantly evolving. So it's a little bit of trying to nail some jello up to the wall, but we can certainly make a good faith effort and give you at least a general understanding. What they're doing.
Before we go forward anymore, I would say at this point in time, the three things I picked up on, I think are critical. One, and hopefully Antonio can get the information. What data do we need to do our job? What our mission needs to have data. So first of all, we have to define what data elements do we think as a board are required to meet our mission. Number two,
At levels of granularity.
correct. And then number two is, where does that data get reported to? You know, if it goes to, trying to get to Edwards, the central database, and we have it collectively, I don't have an issue with that. What I do have concern with though is access to the data. Because if we don't have access to the data, then we have to get to the redundancy, because then we don't have the statutory authority to look at the data, even though you've collected it.
Mm-hmm.
So therefore, we have to be clear that we have the statutory authority to look at the data that's been collected. And if that doesn't happen, then we have to go back to, I think, Mr. Fahey to have redundancy, because we make sure that we have access to the data somewhere. So I think it's more of a policy, if I understand it correctly, to be sure that in the policies that we have, which is the laws, that we're clear about that. So I think it's three things. One, to your point, what data do we need and at what level do we need it? Number two, where does it go? And who has compliance to be sure that we can collect it? And three, who has access to it?
May, as a former data analyst, may I offer that before you get to what data is needed, we need to be clear on which questions we want to be able to answer. You know, and so it's our pursuit of a particular type of answer or information that drives the data that's needed to be analyzed to provide that information. So I agree with your three, but I'm just suggesting that there's a fourth and maybe the first, which is we really should need some clarity on what specifically we're trying to answer.
And that's one of the things we want to tee up for, I think, the next meeting, Mr. Williamson.
Yeah.
Is talking about the mission of this board.
Yeah.
And be clear about that. We talk about affordability to whom and the public payer. We talk about what's the public payer mean. We need that clarification about it. At the same time, depending upon what this board considers a submission based upon the statute and interpretation of it, then we have to go back and talk about how do we meet that mission? Which is back, I think, trying to get to.
Right, and meeting that mission, which questions need to be
Right.
asked and answered.
Which I think is packed in the same thing, maybe somewhat this report is trying to sit there and say, because when I read it here, it's well done, by the way. Thank you for that. But it sounds like this is more about the data collection, the data where it resides, and more about than the mission between the insurance department's mission versus our mission. If I understand it.
Sure. So based off of what I'm hearing, a couple of different things, obviously, but do you feel that it would be beneficial for us to put together a short kind of legal memo for you all to understand under the current law, what information PDAB has the legal authority to access?
And possibly a remedy, like an MOU or something
Or
else
or
that
legislation that clarifies.
that would clarify it and also give, PDAB the access that we need to the database. We don't want to recreate the database. That's expensive and a waste of time. But we want to be able to incorporate that data at its most granular level.
And computer cycles, I mean, we need crunching power, just,
Right, but that's access. I mean, that's the broadest sense of access, but. We already have the confidentiality component, so how do we work it out so that we can have that access and not breach the department's confidentiality requirements?
Don't get into the Met court family.
Not looking to get personally sued. No.
So you got kind of tackled, Mr. Commissioner. You had some idea what you were gonna say to us, and then we started asking questions. Did you get your?
No, it's all good. I'm just here to partake in the conversation.
Yeah,
Thank you.
so thank you for coming.
Thank you.
Thank you.
You bet.
So
Thanks,
when,
Yeah, thank you, Todd. Nice to see you.
Good to see you.
so once we get that data set from Antonio. There's, at that point in time, I think we need to send it to yourself and the insurance department, find out what data elements do we have. What's in the system? And what's not in the system, what do we have to, how do we get it? Does it go, where does it go? Make sense?
may I come back to an earlier point?
Sure.
I think that what you just said is necessary for us to be able to understand the PBM segment of the market. But what I don't know is if it's sufficient for us to look at the other parts of the market that are outside the scope of the PBM.
But I think of and this is to answer what you were just saying, or at least a comment on, if I could, I think that the Department of Insurance it would be a huge expectation on our part that they're going to answer all of our data needs. And that's why I'm really curious to see Dr. Chacha's, when he sends us his list of how what is needed. The insurance department may be just one component. A lot of it's probably publicly available, but we need to be pulling in all the data from across the spectrum. Is that sort of what you're talking about? In other words, there may be more data beyond
Yes.
his and beyond the department's ability to provide.
And to the extent that we can forecast what else is out there, it would be good to get that visibility earlier than later, so that we're guided.
Hopefully we can follow up with him and make sure he sends that up.
Recall that the initial statute required that, we look at prescription drugs that are causing affordability issues on the public payer in the state of New Hampshire. So I think that it would be hard to imagine that it would be some public domain data set that's gonna elucidate those affordability options, like those issues, right? So that's where the claims data comes in. That's where the Department of Administrative Services, as an example, would be, an interesting entity outside the domain of the PDAB, New Hampshire PDAB and New Hampshire Insurance Department to collaborate with. It was left out in the redundancy report because the statute didn't say that. And, I know that Representative Edwards, you intended to have federal government and Department of Administrative Services, but that's an excellent example, Dr. Sherman, of a set of data that would inform the board's missives, but that the insurance department doesn't currently really have a stratified level. We have group IDs that could identify them in the CHIS. Most of the self-funded insured in the claims data is the state employees, university system employees, but they would have that information compartmentalized nicely for the board.
And also, I think we need to go back. And part of the mission is finding ways to reduce drug costs and to develop strategies to accomplish that. However, if we have something as a benchmark, it's hard to actually measure whether we were successful. I think of it this way too, is that when you have financial advisors, and a lot of times look at whether they're doing a good job for you, I would say you go back and you look at, are they beating the S&P 500? If they are consistently getting better than the S&P 500, then they're probably doing a fairly good job, because it's hard to do that. And what I'm trying to get to here with our own is saying, what's the benchmark we're going to use? So if we have recommendations out there, and it could be in biosimilars and the uptakes, whatever it's going to be, looking at drug cost. This is our recommendation. The ones who follow the recommendation, how do they do versus the ones who didn't?
Right.
Because I think at that point in time, that's the value of the PDAB. It's saying these are our recommendations for strategies to bring down your overall drug cost of the public payer. Some will adopt them, some may not, but that's probably a good thing, because then you can look at the two and say the ones that adopted it, what happened versus the ones that didn't. The other side of the coin too is that when you look at drug cost, I look at it saying it's three components to it. One, what drugs chosen, and what Antonio was talking about before. You can have drugs that are slightly modified, they don't really have a lot of clinical significance, but they're patent extensions. So therefore, if our strategy is that you shouldn't be using the newer version of it because the old one still works and it's half the price. So it's drug selected, which is by the prescriber, what the cost of that drug is and what the utilization of it is. Those are the three components I see in a drug cost. If we can find out a recommendation that working with the prescribers and saying, if you prescribe this drug versus that drug, this is again recommendation, but with the plans, that can reduce your drug cost because this drug is half the price of that drug. So those are the things I'm trying to get to, but what I go back to, if we're going to show and demonstrate value, we have to benchmark it against something. You just can't have something out there as a big ocean. You got to be able to demonstrate that some value is brought to the table. So,
Good thought. I think.
yeah. So at the next meeting, we'll talk about the mission of this board. We'll follow up a little bit with the redundancy. I'll talk to Rob Berry about so we get some rules going on the non-lapsing account for contributions to the board. Next meeting, by the way, is on April 22nd. I think maybe you should wait to get the information back from Antonio as far as the data elements. And once we get that, is I would have a discussion with at least Bob, Dr. Woodward, and Dr. Ezes, and also yourself, whoever wants to be there, but another meeting separate from the board meeting to talk about the data.
Yeah. Any questions?
Questions. Okay. But that's something, it's open to the board. It'll be a public meeting. We can't do it.
Yeah.
Can't do it on Zoom. It's open. We have to have-
Mr. Chair, what is your concept of what kind of feedback we give to the insurance department on their report? I mean, do you see this sort of informal verbal stuff as being adequate to our feedback, or do you see something more formal? And what timeline are you thinking? I'm just trying to understand the process you might have.
My thought is that sometime either in April or May, is probably April, is for us to start talking about the feedback back to the insurance department on their report. This was more of a presentation on it. We have time to digest it, think about it.
Yep.
And then hopefully reflect on it, and then maybe in April, have some time to talk about some feedback to us.
Thank you.
Okay.
Can I ask a question in terms of that exchange going back? One of the issues in one of the questions that came up was the confidentiality and what was what would be confidential or proprietary data. As we talk about the data elements, it would be useful to, in that discussion, sort of put on the board, you know, what levels of access are different. That is, Commissioner Betancourt was concerned about being sued, his family fund. You know, what are the elements about which suit might be generated? That level of detail, so that we can address it then specifically if need be with legislation. Right now, I mean, I can see him saying it's, you know, I'd like to do as much as possible, but that's illegal on a pretty wide range of data. I mean, you know, just how old somebody is in a particular region can be proprietary data if that is the only person, or there are less than 5 people in that region. One needs to be the details to really know what I'm talking about.
So can I mention that, in the world of privacy for personal data, that it's really well defined what kind of data elements are considered to be personal data, and the kind of limitation of aggregating the data to still maintain privacy. So
Well,
I just don't know in the business proprietary world, if the models are as well defined as you're suggesting.
As I'm worried about, I'm asking the question, I don't know the answer.
So I look forward to the opportunity in this meeting that Representative March is talking about, to do a quick presentation to show across the several different domains, because we get a lot of different types of data. For example, one of the most restrictive 2 data points, sets of data that we get are the PBM reporting data that has the total drug spend and the aggregate rebates. That all has to be aggregated. I mean, it's very clear, so we cannot disaggregate that at the TBM level. Whereas in the CHIS data, the claims data, we work with a vendor and they double de-identify that. So it's well protected and, you know, non-identifiable at the individual level. Certain parameters are more sensitive than others, but I would show across the continuum of data that we do get, you know, what we can release and how. I'll ask all of you to, and I can send the link to the chairman and our executive director to view our dashboards, prescription drug cost and utilization dashboard, so you'll get to see what's public facing, and if it's public facing, we can use it and talk about it here.
Or, go ahead.
Mr. Bay,
Thank you, Mr. Chairman. To Representative Edwards' point, it would seem to me that we would owe the commissioner and his team the courtesy of a written response to that report with our feedback. I'm not sure if that would be the pleasure of the board or not, but it would certainly be mine. At the appropriate time, once we've all considered it.
that's a very good point, Mr. Bay. I think after the next meeting, we have a chance to reflect on it and put our heads together. And I think at that point in time is talk about how to respond to the report, at least at the draft, if you will, the report. Some recommendations. So following that report in April, I think we should follow up with a written report back to the commissioner.
Should we anticipate SB 555 or some version of it getting passed? I mean, it's sort of like we're shooting at a moving target.
Well, I think it's gonna be important with SB 555 is that we can use it as a vehicle if we need to, based upon the reports, what we're saying to get through what we need to get through.
Hmm.
So is there anything else at this point in time? I want to say thank you to Mr. Williamson for getting the advisory council off the list.
That's great.
It's awesome. It's been a long time overdue, so your work.
Can I
Yeah,
just
please.
say on the advisory council,
Yeah.
one of the things that it does give us is, and I don't think this is in the statute, but it gives us all of those entities that we're talking about reaching out to for additional data. It gives us a relationship with them.
Yep.
So it might be something where once those designees are all in place and we've got that, they can be our go-to person
Good point.
for additional data like corrections. I have to go back and look. Is corrections one of them?
Yep.
It is, isn't it? Yeah. So I just, think it's kind of cool to have that formal mechanism of interaction across departments. That we can tackle.
Yeah, absolutely. Any more? No, last thing on the agenda is public comments. We have the public here, so any comments from anyone in the public? Why? None?
Sorry to disappoint.
Yeah, very good.
There's
So Mr.
somebody, there's someone
Yeah.
else who'd like to speak.
All right, sure.
Hi, can you hear me?
We can, thank you.
Awesome. I'm not sure if my camera will work, so I'll just speak. My name is Mary Beth Garino. I'm the healthcare advocate at New Hampshire PIRG. We're a statewide consumer advocacy organization representing hundreds of state residents. And I'll be submitting written comments after the hearing, but I did want to just highlight our support for the board and its work. Prescription drug prices, as you know, are rising and driving up the cost of healthcare for patients, insured families, and our state and federal health programs. And drug manufacturers are using a variety of anti-competitive tactics to delay or block lower cost generics and biosimilar drugs from making it to pharmacy shelves. With monopolies and other anti-competitive tactics, the companies that make these drugs can set their prices at whatever level they want and can raise those prices every year without any justification, as you all heard today in the presentation. So we really support the work that this board is doing. It's an important tool to combat poor health outcomes due to high prices of prescription medication. And we believe, as we've heard today, to be successful, the PDAB really needs the right data to analyze the drugs and the prices New Hampshire's residents' health plans, our state programs are paying. So we really support the work that you're doing. We believe you have an important role to play, and I look forward to further collaboration on this effort. Thank you.
Thank you.
Yeah.
I'll put a little plug into House Bill 1365, which is the biologics biosimilar bill. I believe is going to make it through the House and over to the Senate, but you may want to think about testifying in support of that bill when it does get to the Senate. Any additional comments from the public?
No.
No? With that, I'll adjourn the meeting. Have a motion. Motion by
Second.
second. All those in favor say aye.
Aye.
Okay,
Thank
we're adjourned.
Are we off the air?